apparently looks like a little can be pretty abstract or boring, but I'll try my best to make it more engaging to the best of my knowledge. And so we've had this declaration, and in this my few minutes of presentation, we'll get to take quite some tidbits of this resolution, look at the roles and frameworks in skin health implementation plans, then the implementation areas as our focus. And as much as possible, I will try to give real life examples so that we do not just talk technical terms and we don't get the bits of it. So we need to remind ourselves again, the core words, the declaration. Beyond the declaration, there has to be a propagation, there has to be an implementation, then an evaluation. The level we are now is that, yes, WHO declared last year, actionable points are being generated and some level of implementation have started. Interestingly, I think, to the best of my knowledge, NAD was the first professional organization globally to have a discussion on the World Health Assembly. I think it was about a week or so thereafter that we had that British American BAD, British Association of Dermatologists. So this again is another opportunity to show the strong impact the Nigerian dermatologists are bringing on board in this regard. Of course, skin diseases, we need to continue to remind ourselves the enormity of skin diseases. And we need to also understand that skin diseases have gone beyond the village where I typically say, and I call myself a village man. It has become a global disease, and not just a global disease, it is a disease that has a priority. And that means that with this declaration, each and every dermatologist in Nigeria and all over the world has that free access and that gateway card to reach your head of department, to reach our director of clinical services, director of administration, director of finance, chief medical director, and seek for more recognition for facilities in dermatology, training of medical students and undergraduates, policy formulation within the hospital, and a host of others. And so this is what this declaration brings to us. But again, beyond the declaration, what next? Yes, the declaration is there. What exactly does it mean for us? I've had quite a number of people ask me, oh, Seb, this declaration is just, what does it mean for an average community member, for the dermatologist, and for everyone? And so it's important that this declaration is made. That's why this has become, skin diseases have become global priority. It's important to remind ourselves again that it's not everybody that may be versed in health policy. It's not everybody that may be versed in research. Not everybody can lecture. But the most important thing is that everyone can be the best in every area we choose. And this is where each and every one of us can begin to zero in on how we can make impact based on this declaration. I am a dermatologist with research bias in infectious dermatosis. I want to go forward to ensure that in that area of infectious dermatosis and infectious disease, I want not just my patients to get well, I want the hospital, the department to feel the impact. And beyond that, I want to be able to translate whatever I find at the bedside into implementable policies, because this is what this action is telling us. This is what this declaration is giving to us. This is what the attempt to ensure we have a globally acceptable, implementable, and effective and efficacious global action plan means to us. So let every one of us pick each area where this seems to help us practice better, become better dermatologists, and ensure we get things done. We need to remind ourselves again that skin diseases form one of the top 10 diseases and affect more than 4 billion people all over the world, and ranks high on disability associated with skin diseases. But despite all of these issues, we have concerns with access to care in the area of skilled manpower dermatologists, access to care, even with the distribution of the few dermatologists, access to care with facilities, drug diagnosis. So we should remember this. And when we practice in Nigeria, we are on daily basis being inundated with many of these things. So how do we pick what concerns us in this global basket of WHO declaration and see how we can make that woman in our community, that patient that comes to our clinic, feel more impact, our states feel more impact. We shall use some case studies. Skin bleaching in Nigeria is globally known, and so we decided, and we've had quite some discussions on this on the NAD page, Mpox, NTDs, and in very recent times, the MDTs for leprosy, the drugs for leprosy and other communicable diseases. We've been having quite some brainstorming on how we can go around the issues surrounding the difficulty with getting drugs for patients with leprosy. And so this is an area those who have that intent and expertise in this area can move beyond just raising the concern, but reaching those in power in the appropriate places in the state government, the federal government, the ministry, the policymakers, the politicians, our political leaders, all of them. This is what this declaration is asking us to do as dermatologists. Like I said, Mpox, yeah, we're still battling with Mpox, and Nigeria, we're still reporting positive Mpox cases. But Mpox reminds us of what I call the elder brother, smallpox. There are a number of people who still live with the scar of smallpox till today. They may not have had Mpox, but the impact is there. And that touches again on the quality of life. If you're a dermatologist with an expertise in quality of life, the WHO declaration is calling you to go beyond just managing patients to getting all of our clinical findings into implementable policies, because this would be a strong point I want to appeal for and push for at this seminar. Beyond just making diagnoses, beyond just making core clinical findings, and of course, writing them out in global I want to appeal we go beyond that to ensure that we get ourselves to the level where we are able to inform the policymakers, where we are able to inform our leaders, where we are able to reach our communities to make the best of these findings. And if I will quickly just go through just some basic tenets, even with bridging the no-do gap, because that is an area again at the global level that the focus is on. And if we look at various scales.
Dr. Oyewa, we're just seeing you. We can't see your slides.
Yes, I'm trying to, it's coming up soon. So if we're able to look through at those areas where how we can bridge the no-do gap. The no-do gap is an area globally that has to do with what I know, how am I able to bridge that knowledge and make it what is very implementable. And so this area is important at this discussion. And when we look at areas of knowledge is the most basal of all scales that measures human impact. That I know the stuff on Mpox, and my knowledge does not transform to impacts that the man in my village can feel, then I'm not doing the necessary thing in this WHO declaration. So this presentation today is calling us to go beyond our findings at the ward rounds on the bedside to ensure that in all areas of our various roles as dermatologists in diagnosis and management, we should move beyond that to ensure that we're able to advance it to the level of policy formulation. We're able to help relevant stakeholders in the ministry, just like we've just seen just a few days ago, federal government instituted a working group that will look at safety of these cosmetic products. A lot more are coming. So we lend our voices. Other areas where we have impact, public health surveillance. Do not say that I'm a dermatologist, I do not have a role in public health. No, everyone has a role in public health. We can decide and say, oh, based on what I've found, let me link up with the hospital personnel in public health. This is what I've found. Can you go into the community and help me let's find out what exactly is happening. We go beyond that to reach the state ministry of health. We go beyond that to federal government. Research, beyond what we do, what we publish, can we make a way to ensure that all of these publications by relevant evidence synthesis processes, we're able to get this into policies that can be translated to even laws and bills, that can affect the common man. Capacity training. Before we can show that yes, we are who we are as dermatologists, we need to hone more of our skills in various areas of strengthening our skills in our respective areas of focus as dermatologists, even in education and various areas, in strategic planning, in outbreak responses. We need to do. That's what the WHA is calling us to do. And for us to effectively do this, there are fundamental frameworks I want to propose, which I think that they become very important for us as dermatologists to do this. We do understand that this is an innovation, it's a new thing. And there is the diffusion innovation theory that says that the innovators are usually less than 15% when it comes to implementation of those policies. This presentation is bringing on the spot the need for us to be among the early adopters, not late adopters and not the laggards like we'll see in other areas. We need to also have understanding of the McKinsey 7S of organizational structure, because before you can break into every organization where you think impact can be made, either state government, state ministry of health, federal ministry of health, you need to understand the core values. You need to understand the language. You need to understand everything there. Then in the area of skill and development, how often do we assess our skill competencies based on even when we decide to use the Miller's pyramid or the Dreyfus model that grades skills into from novice to experts, Then our research capabilities. How do we translate our research into implementable policies? I have seen patients with mpox. I've seen dynamics in mpox that is different from what Dr. Akikube have been discussing with her. How do I bring this into focus to say, okay, can we put together the Lagos experience, the Irua experience, and all experience in dermatology into policy? This is what NAD has done in the publication of the mpox protocol. And I make dare to say, with all humility, that that is the first of such mpox policy in Nigeria and globally by a professional organization, which is what is commendable. And in the area of policy, I think we also need to get to understand policy cycles, governance cycles, the pillars of governance, and a lot more. That's why the comma is there. We need to, so this is the diffusion innovation theory that talks about innovators. These are those in this instance that pushed for this declaration to be made. And interestingly, Nigeria was part of the countries that adopted this. Nigeria, Micronesia, Cote d'Ivoire, Togo, China, Egypt. And so we are the innovators. And so every Nigerian dermatologist fall into this area of innovators. Early adopters, we need to get more people, more dermatologists, more stakeholders to get to this. So understanding this would also know that before we can break into every area that we feel we have not gone to, yes, we have done well in our area of dermatology. We have so much publications, but are we able to break into the structure of the ministry to be able to speak the language you understand? Are we able to understand the of collaboration? Are we able to hone our skills into more expertise in this area? What is our style of communication? Are we able to have a better understanding of the organizational staffing and everything? Then, of course, if we look at the Dreyfus model here, we would see that it has graded all areas of competencies from novice to expert, various competencies, from just learning theoretical knowledge to the various areas. But I had to bring this on to show that we need to also hone our skills in some relevant areas so that we can bring our very respected roles to usefulness outside of the clinic. Then again, in terms of education and clinical skills, we have our teachers here, various areas we can assess knowledge of our students. This World Health Assembly Declaration also talks about access to care. If we need more dermatologists, I think the strategy has to be focusing on getting more medical students to have better knowledge of dermatology, so that we plant this in them, so that in future we have more dermatologists. And there are various skill areas that we can look at. And if we look at both of them, you will just see that knowledge is the least in all of them. So having a knowledge of any aspect in dermatology is the least. How well are we able to show that we know this knowledge, we can practice this knowledge and show expertise in this area? How well can we evaluate ourselves and our actions in this area? Of course, stakeholders analysis is one very important step in policy development, agenda for various areas in public health and global health. And of course, we can see in this picture of various stakeholders at the global level, and again, even at the national level, would be able to see various levels of engagement. We would see that at the global level, WHO, ILDS, NNN, patient organizations. But the one that I think will be of useful importance to us is at the country level and health facility level and community level. These are people we need to engage so as to propagate this declaration. The Ministry of Health, the federal, the state, even local government, for those of us who work in local government, for those of us who work in NGOs, these are areas we need to push this agenda and ensure that we have a viral structure that would engender better skin health related policies, better political will for skin health. Then health facilities. Some of us, our teachers here, are occupying and are occupied positions in hospital management committees, directorates of clinical services. So these are stakeholders we need to convince, so that at every year we can begin to develop proposals as dermatology units in every hospital to present to the hospital. And we have the free card of the declaration, so that we'll have more facilities, we have more technical know-how, and there can be more training, sponsorship in this area. And at the community, how well are we able to translate this? There is high rate of skin bleaching from our clinic, and we've noticed there is a nidus where this is coming from. Beyond sitting in the clinic, can we not go into that area and meet with these people? Oh, this is what I've noticed. Dr. Ko shared an experience, and I've also read quite some very commendable publications from dermatologists looking into the content of the skin bleaching cream, going into these areas where the skin bleaching creams are. We look at them, then we speak with the policy holders, we speak with the religious leaders, speak with the traditional leaders, and make them know the danger in this. This way, we would have been able to transform this policy into what is implementable, and the goal will be a change in behavior even at the community level. Of course, these are stakeholders that I've already mentioned before. So more focus will now be on the Nigerian effort. Federal Ministry of Health. It's good to know again, which I've mentioned before, that the Ministry of Health now has, for the first time in history, a desk officer, a program manager on skin NTDs. While some of us may say, oh, it's just skin NTDs, but it is a laudable step that we can build on. We look forward to the day where the Ministry of Health will have a department of skin health, where dermatologists will play a role. There will be better collaboration. NADs, our teachers will be doing great jobs. We've produced, we've replicated ourselves over and over again. That in itself is laudable. And for those of us that have been taught, we need to also do that again and beyond in the areas of education, advocacy, research, guidelines development. In a few weeks ago, I was having a chat with some people, and they raised a vital issue that how many centers in Nigeria have written guidelines. Say, for instance, guideline for the management of psoriasis in my hospital, guideline for the management of skin bleaching and its complication. And we write this down and show to management and document it down in the hospital so that that becomes a policy document in the hospital. This is what this declaration is asking us to do. Advisories. As dermatologists in the hospital, we walk around and we see things that are of danger to us, even climate change. We can do a short memo to the CMD that, oh, based on the fact that skin diseases have become global priority, I have noticed this in the last few days, sir, I propose this. These are the strategies, these are the actions, these are evaluation frameworks. And we hope that in the next 1 year, we hope that based on these key performance indicators, we can see this, and that. In that way, I'm sure every CMD will present this as part of their yearly report to the ministry and would have made more impact in this area. Going forward again, I would use ISTH model. At least that's what I know. From the beginning of this advocacies for WHO to recognize skin diseases, we moved the dermatology units, we wrote to the CMD. CMD adopted the agenda. From the CMD recommended to the minister. The minister then, by the authorization of the president, sent a letter of support. And this helped us, in addition with other countries, to get these declarations. And so, like I will always say at every point, just like we went from hospital, from dermatology unit to hospital, to ministry and WHO, the way up is the way down. WHO can now, and I know as a member of the team, the plan for WHO is to have a globalization of effort. Yeah, beyond globalization, we need to get everyone involved. The way up is the way down. Every necessary expert needs to be involved in this area. And of course, implementation strategies. We can decide to put this into play. Short-term, mid-term, long-term, and what I call transgenerational. These are strategies that would live beyond us. We can have, there's nothing stopping us from having a 50-year strategic plan. What is more common is 5-year, 10-year strategic plan, but there's nothing wrong in us having 50-year strategic plan on skin diseases. NAD can propose that, and over generations would have the impact and would continue to do that. And at WHO level, WHO serves as a coordinating body, serves leadership roles, and at the moment there is the process of the development of the global action plan that intends to put all of these areas that I've mentioned and many more into focus, so that once the global action plan is out, it will be easy to implement in my village where I practice. It will be easy to implement in Abuja, in my Tama there. It will be easy to implement in VI. It will be easy to implement in Kano, so that everyone together will speak the language that the end user, the patient, and the community understand, and we'll be able to get them to know what this means to us. Then, of course, we scale up activities in this area. At country level, we mentioned the need for us to strengthen efforts at finance and human resources. I think that I want to make a proposition that, yes, arising from here, we should make plans that before the end of the year, by the time the budget of the hospital is being drawn, every dermatology unit can make a special budgetary proposal to the management that for next year, this is what we want, this is what we propose, in line with WHO agenda. And I'm sure it will be easily defendable at the ministry based on this backing document we have. Diagnostic facilities, integration with other programs. There are other programs that will have many program integration. In one of my papers that just got the advanced copy just got published online in the British Journal of Dermatologists, is on the role and skill of dermatologists in Africa in mpox. We're able to look at various areas that delved into capacity, access to care, the epidemiological importance of dermatologists. And finally, we zeroed in on the role of integrated model of care. And this integrated model of care reduces helps us go around the challenge of low resources. Say, for instance, yes, we want to start a policy on mpox. If there's no money to start a standalone mpox program, in that our publication, we pushed that yes, you can integrate mpox into HIV program. You can integrate mpox into NTD, which was what we actually proposed in that publication. You can integrate mpox into associated programs. That way, it will not be a dead end whenever we present to policymakers. Because whenever we present policies, from my little experience, the moment the money is getting much, they just KIV it. But the moment we present it and say, sir, ma, we know this is the cost. However, we are proposing an integrated model into an already existing program wherein we would not need much financial resources, will not need much human resources, we'll be ready to give our best. This way, we are able to make it more acceptable to that man that sits atop every proposal, application, and approval in the hospital, in the state, and at the federal level. Innovations and other areas that we can do. We can decide that, yes, for every area of our expertise, cosmetic dermatology, you can have an expert, you can have a champion on cosmetic dermatology. The best way to carry out aesthetic medicine practices, the best way to seek help, the best way to use some of these products. Influencers who have knowledge that we can impact on them in languages they understand. Then we also, traditional rulers, speak the language they understand. We reach them in culturally acceptable ways so that we explain to them what we want. This way, even when we are not there, the propagation of the WHO declaration becomes spoken in languages that we cannot even speak. The small child who does not understand can get that. Religious leaders, we can get them to do all of this. Of course, during all of this process, conflicts will always arise. Conflict of ideas, conflict of ego, conflict of effort, conflict of all areas. Questions like, oh, despite all I've done, is this what I can get from these people? I'm pushing this idea at. These people are not responding. What do I do? All of our efforts are ending up in this, and that. Yes, conflict will arise. Conflicts are not abnormal. In fact, conflicts test the best of organizational structure and function. And to understand this, I'm proposing the Tomokima's conflict model that looks at, on one end, assertion, and looks at the other end, cooperation. Bringing all of this into focus at various times, we can achieve our goals most effectively. The lowest hanging fruit for us, which I propose, NAD Vision 2035, where we can say, okay, skin bleaching, I will propose that through various efforts, 1, 2, 3, 4, 5, we want to aim for 10% yearly decrease in the prevalence of skin bleaching over the next 10 years. We want to ensure that the complications of skin bleaching goes down by 10%. In this way, we collaborate with nephrologists. In this way, we collaborate with endocrinologists. In this way, we collaborate with public health physicians. We come together to develop a strategic plan that can help us implement this. We do appropriate stakeholder analysis. Beyond these 3 professionals I've mentioned, risk communication experts are there. We have NGO partners. We have a lot of people. In this way, we are able to develop formidable framework that would endure even beyond our years of practice. In conclusion, the World Health Assembly Declaration is auspicious, sorry, not suspicious, auspicious, epoch-making. Beyond the euphoria, there is the need to strengthen efforts in implementation, monitoring, and evaluation efforts. And dermatologists, I dare say, have a role to play in all areas. In all areas. There is therefore a need for scaling in skills and competencies to get the best of skillness. And as I've corrected, WHA declaration is auspicious and epoch-making. On this note, I want to say thank you. And I do hope that this becomes an icebreaker that will raise questions that we can answer. Thank you.
Thank you very much, Dr. Oiwu, for this insightful presentation. Okay, before I give a summary of the presentation, please, if you have any comments, question, kindly put in the chat box. Or after this, you could you could put a show of hand to either make your question or comment. Thank you again, Dr. Oiwu, for the presentation. Your discussion has clearly highlighted the crucial role dermatologists must play in advancing the World Health Assembly resolution of skin diseases. You started off by reminding us that skin diseases are of global health priority, and you went further to highlight the global burden of disease and how skin diseases contribute a huge burden in disability adjusted life years, and to the low awareness of skin diseases and the low representation of dermatologists in the medical workforce. You stated the importance of this World Health Declaration. The importance of the World Health Declaration, where you mentioned that while everybody cannot do everything, health policy, research, lecture, but everyone can be best in whatever skill he or she chooses. He or she chooses. So you gave, you stated the, please a minute, you cited areas of examples where despite the burden of skin diseases, we are still faced with access to dermatologic care. You mentioned particularly the shortfall of multi-drug treatment for leprosy, and also the case studies in skin bleaching in Nigeria, mpox, and neglected tropical diseases. As part of the declaration, you've made us to know that we need to keep advocating in the aspect of transforming our clinical findings, clinical experiences into implementable findings and policy formulation. And you went further to demystify the role of dermatologists in this World Health Assembly resolution. You talked about diagnosis and management, which we are very much equipped with, and stated that this needs to go beyond clinical, the hospital, and the bedside to the research and publishing these researches so that these can be put forward for policy formulation, implementation, and evaluation. We talked about partnership with relevant stakeholders, and also the role of dermatology in training health workers. It well stated that the dermatologists are poorly represented in the medical workforce. They talked about strategic planning and outbreak responses. So these are the key roles of dermatology in skin health. Then to achieve this role, or to carry out these roles, you stated the fundamental framework that can be used to carry out this role, pointing to this should be based on understanding of innovation, to being based on organizations structure, then skill development and competence, which is at different levels, and stating that acquiring knowledge is just one of the list of these are skill development and competence, then also based on research capacity, capabilities, and on policies and on policies. Then you emphasize stakeholders analysis and convocation, and this can be at different levels, from the international bodies, but you stated that we should bring it down to the country level, where we have the role of NAD, the Federal Ministry of Health, then the community level, where we have the religious leaders and the community rulers, then at the hospital level, even the non-governmental and even private establishments. Then talked about the implementation strategy, which could be short, medium, or longer term. In all of this, you mentioned the conflicts can arise in the course of this having this declaration, and this can be handled using the Thomas Clemens conflict model in handling conflicts that may arise. And conclusively, you emphasize that skin disease is of public health priority, and this has been well recognized by the World Health Assembly, and that dermatologists have key roles to play in this World Health resolution, and that there is need for upscaling in skills and competence to get the best of skin health. Thank you, Dr. Oyewo, once again for this insightful discourse. So I don't know if we have, let me go to the chat, comments, questions. For those that want to speak, please put a show of hands and you'll be allowed to speak. Thank you.
Dr. Iwa, thank you. Please, could you just stop sharing your screen so that can.
Please kindly put up comments, question in the chat box. Thank you. Okay, from the chat box, there are no questions, no comments.
There are no questions. Yeah. Okay. If there are no questions, then I would like to say thank you very much to Dr. Oiwa. I think he delivered. Oh, somebody's hand is up. Okay.
Okay, ma'am. Please go on.
Thank you very much. Can you hear me?
Yes, we can.
Okay, thank you.
Yes,
Thank you,
we can.
Dr. Oyewo. Thank you so much for this your talk and then your passion and your zeal. And we're hoping that that passion translates to all of us who are listening. I have a comment, and it's related to, I think one of your slides you were talking about conflicts and what we can do with maybe poor responders or maybe some sort of ineptitude. I think I don't remember exactly how you coined it, but the bottom line was when you feel discouraged, when you think that some things are not going on. Do you remember there was one slide like that? Okay, so if I remember correctly, if I think about all the things that we've tried to do as the NAD and the group of specialists over the years in advocating, I would say leprosy has been maybe one of the major diseases that we have pushed and pushed and pushed. I would say leprosy. Yes, everybody's always talking about bleaching and all that, but in terms of when we talk about policies and where maybe the government has been involved, government at all levels, they are always almost involved. Now, if I were to use just that leprosy as the case study, I think you put about 4 or 5 case studies. Can you authentically say, you or anybody else on this call, tell me why I shouldn't be discouraged and why I should bother with any of the rest. Because year in, year out, we have them in every meeting that we have. And that's something that we do, just like the way we call NAFDAC. We have them in every meeting. We have seen not once, not twice when there'll be something going on in the Federal Republic in National Assembly, and they will seem to do one policy, and then we will hear about it after the fact. Then start scrambling to say, oh, we are here. You guys didn't consider us. And I don't know, except we are not seeing. I don't know that there is any other thing that the so-called leprosy groups that are not dermatologists, whoever they may be, whether in the ministry, state or federal, are doing that we will not hear about it. So that one can't actually say, okay, maybe they are doing and they've not involved us. More often than not, we are hearing about anything after the fact. And there seems to be some policies. We hear about it when monies are being made. Now, how else? So that's that one. And think about the impacts and how do you measure the outcome of whatever it is that whether we without them or we with them or them alone. And this them, anybody else apart from the NAD. I'm just trying to put it all out there. How do we measure the impact of whatever it is that have been done over the last, for argument's sake, let me just say 15 years, because I'm sure before me, it was already being done. The different foundations that have been there. It seems to me, I may be wrong, and I really, really hope I am wrong. It seems to me that we are just talking. It is very shallow. I don't know that we are really going downwards, like you were saying, which is very correct. So a lot of things sound very nice and plush and very highfalutin on paper or in presentations. And when you see them coming, it sounds like so. And I think we kind of like we are kowtowing to them when they come for all of these things. And then we sort of like, short of the colloquial way is say ophthalmology. You're just doing maybe some sort of eye service sort of thing. But in the impact, because we're still seeing patients with this, we still don't know, we can still tell that primary healthcare workers can't identify early leprosy, which are the things that we're trying to push. We can still see that the medication, in fact, if anything, is struggling. Before we were better off where we knew that the patients could actually get the meds. Now it's sort of a bit longer, some long winding road that to go get this, and then you can't get some, you can get some. I don't know that we are actually making a lot of headway. Is it that we don't have the right parameters of measurement of outcomes, one, or maybe, and I'm using us in Lagos, because I can't speak, but it's not just Lagos, because when I even go for NAD, I hear what other people are presenting. So I don't even think it's a Lagos thing. But I still see the ends of leprosy coming to us. I still hear people thinking, is leprosy still in Nigeria? When we look at the numbers, it seems that we're just there. So is it that we're playing with our numbers? Are we just banding numbers around, or what exactly are we doing? Now, if you use that leprosy, then you now think about the other so-called case studies. I don't want to go into skin bleaching because that one, let's not even talk about it at all. Then we talk Mpox, which I think is because it is the new kid on the block. Everybody's going that way. And then, so for me, and this is me just speaking for me, it's one thing to be passionate, but it's another thing not to burn out because you can't see the end. And that's the conflict we're talking about. There are a lot of people now. I'm seeing Dr. Akikwe talk about that only 37 people on this call. People are tired. Year in, year out, we're speaking the same grammar. People are tired. And WHO can say something because now it's good that they're looking at us that, okay, the African population is the one that will swallow the rest of the world. Things haven't gone. We have to be very, very, we have to call it a spade, and not just a farming implement. We are seemingly all being courted, as it were, with the international community because, yes, there's a lot of work to be done in Africa. There's a lot of work to be done in Africa. But what are we, Africans ourselves? How are we really how are we treating self? I don't know if I'm speaking grammar. I'm sorry. I'm hoping I'm making some sense, yeah. But these are my questions, please. Thank you.
Thank you very much, ma'am. I think Dr. Akikube also has a hand. I don't know if you prefer, I take Dr. Ray's question first before hers. Hello, ma'am. Okay, so I'll just speak to Dr. Ray's questions and concerns. I'm very glad that we're having this, I think I'll call it open mic session, because the truth of the matter is when we don't speak truth to ourselves, we end up deceiving ourselves, thinking that we're doing something magical. And it's also good to hear these concerns. And that's why I specifically put that slide of conflict there, because I understand that so much effort. In fact, I didn't know that our grandma was following the discussion. That's Professor Lumide. And when she started telling us how much of effort they had even put into all of this for over 40 years, I begin to wonder that, oh, should we have even bothered me that may neonate or just almost a nobody where Mama speaks. But again, we still have to continue to do all that we can to ensure we push these frontiers. We should not be deterred by the challenges. The strength of a good leader and manager is not in kowtowing to challenges, but rather gliding on the wings of the challenge to arrive at our goal. In terms of key performance indicators of our efforts that we've done over the years, can we look at representation of dermatologists on some of this framework working group steering committee? Do we have at least one dermatologist there at the state level and federal level across specific programs, leprosy, borreliosa, NTDs, and a few others? Do we have one? Do we have two? Do we have dermatologists functioning and giving experts, active expert role, playing active expert role across these programs? Do we also have, in terms, let's now come down to epidemiology of the diseases, key performance indicators? Can we say that our involvement over the years in any of these four areas, particularly leprosy that you've mentioned, has led to some reduction in leprosy? From the data that I have, I know that over the last 5-10 years, we've always had more than 1,000 cases. I think we're still hovering around 1,500. I'm yet to get the data for last year. Compared to the previous years, have there been any impact? Another important key performance indicator is that of all the patients that are seen for leprosy, how many of them are managed by dermatologists? That's also an area, because what we do have oftentimes is that many, from my understanding, I stand corrected, that most of these patients in Nigeria are managed in primary healthcare centers. Fantastic. That's the framework of all engagement. But how many of these health centers have direct engagements with the nearest dermatologist to them? Another key performance indicator we may want to look at is the complication, disabilities. How much of disabilities have we been able to reduce? How much of the other complications have we been able to, linkages of care, how much of this have we been able to achieve? Just like you mentioned, yeah, it can be very fantastic speaking grammar, but the most important thing is translating this grammar to efforts that would last. While I understand that it can be very discouraging, but I think that in my optimistic self that I call myself an incurable optimist, I think that the little drops of our efforts, which may not have been sufficient enough to be classified as a rainfall, is actually adding to whatever positives we have recorded in skin health. I know amongst all entities in Nigeria, WHO has given Nigeria thumbs up in leprosy. And I think to a large extent, we're making efforts, even though these efforts may not be gargantuan, but at least I think we are, and we'll continue to build on it while we hope for better outcomes. Thank you.
So thank you very much, Dr. Oiwa. My network went off. I think I'm back on. Can you hear me?
Yes, I can hear you, ma'am.
So I was just trying to respond to Dr. Trofanoe's, comments, of which I fully support her. We cannot give up. And we need to, like, there's a slide you put up, and I've posted it on our chat. We need to get involved at different levels. Clinicians, as researchers, policy. These people that are up there, and the leprosy NTB LP program, we have been, I don't want to say we have been fighting. We have been trying to prove what needs to be done over the past decade. Slowly but surely, I feel we must not give up. And let me give you an example. There are no leprosy drugs currently. Only 3 or 4 people were actively trying to fight this. We posted something on NAD. Why is it that every single dermatologist did not post this on social media? I was actually going to end by talking about our role with social media. Every single dermatologist should post it, should tag their commissioner of health, should tag the minister of health, and should tag the government. The people out there doing these things, they're getting where they're going because this is what